Part of our two-part series on review of imaging the non-arthritic hip, and we will be talking primarily about MRI. So we already went through some of the causes of intra-articular hip pathology, and today we will focus our attention on the extra-articular area. Now when we think about the extra-articular hip, we think about four areas: the superior portion, the lateral portion, the anterior portion, and the posterior portion. The superior consists of the ASIS, or the anterior superior iliac spine. The lateral portion is the greater trochanter. The anterior portion is the psoas and the rectus femoris, and the posterior portion is the hamstring and the ischiofemoral space. So let's just take a look at these muscles on a regular axial MRI image. Posteriorly at the ischial tuberosity here, you have your hamstrings. As we look a little bit further on, you have posteriorly the glutei in this area. Then you have the short external rotators, which is essentially the obturator internus along with the gemellus superior and inferior. Anteriorly we have the adductors here, the adductor longus, brevis and magnus. Then we have the iliopsoas muscle here anteriorly and the iliopsoas bursa that runs along with it. And then we have the anterior extensors of the thigh, including the iliotibial band, and then along with the sartorius, gracilis and semimembranosus. The first area that we look at superiorly is the iliac crest, and in the iliac crest a common area for injury is the anterior superior iliac spine where the sartorius muscle attaches. You can get avulsion injuries here, and here on the radiograph you can see that there's a very subtle asymmetry in the apophysis here as compared to the opposite side, which is a clue to an apophyseal avulsion injury, and on MRI here it's shown nicely with the bone marrow edema. Another area that is becoming increasingly of concern is the gluteal aponeurotic fascia, which attaches along the iliac crest, and one may see small acute tears or larger tears that are from trauma or degeneration in this area. So the gluteal aponeurotic fascia is becoming an increased cause and concern for pain in the acute and chronic settings. The three glutei muscles, the maximus, the medius and the minimus. The medius is the one that is most commonly affected and should be looked at carefully. One should be fairly familiar with the anatomy of these structures. On an axial image at the greater trochanter, you have most anteriorly the gluteus minimus, then you have laterally a lateral head of the gluteus medius, and then you have a more posterior attachment of the gluteus medius. These would be the three tendinous attachments one needs to be aware of. And as we scroll from anterior to posterior, you will see the lateral head of the gluteus medius. Anteriorly you will see the minimus, and then more posteriorly you will see the medius. Here is an example of somebody where you can see this is the normal minimus tendon here anteriorly. This is the normal sort of posterior tendon of the gluteus medius, and here you have a lateral head gluteus medius tear, which is this area of high signal here, or this little area of high signal in this area. Here you can see another example of a gluteus minimus partial tear. So you can see the anterior tendon is involved here, and therefore this is a gluteus minimus partial tear. One of the things that you should remember, just like the shoulder, the hip can also be involved with calcific periarthritis. The edema around the joint can be quite exuberant, and one could be concerned about hematomas, collections, tumors, etc. And it's very, very important in these cases that you look at X-rays or CTs, because you will find this subtle focus of calcification that will make you look very silly if you didn't look at those other studies. So focal areas of calcification, one should be very, very careful to look for, especially when you see intense soft tissue edema. Remember to look for calcific periarthritis. Here's an example of somebody with intense gluteus medius muscle edema, and when you look at this a little bit more closely, you can see these heterogeneous areas within the muscle here. When you look still more closely, you can see these heterogeneous areas, and on a CT you can see these areas of heterogeneous calcification. And so this is nothing but an example of myositis ossificans, which in its early stages will have extensive exuberant edema surrounding it. The iliopsoas is a commonly affected tendon. You should remember that there's the psoas major and the iliacus, which come together and form a common tendon that attaches at the lesser trochanter. So here you can see the muscle as it runs anteriorly here all the way down to the lesser trochanter. This is the iliopsoas. You can see it anteriorly here as well. Okay, so this is your iliopsoas muscle, and then here you can see the tendon coming and attaching to the lesser tuberosity. And you can see them as they come down on sequential images. One of the things that people talk about is a snapping hip. It's a difficult diagnosis to make on an MRI, but sometimes you'll see fluid around the iliopsoas tendon, and sometimes you'll see this sort of semicircular, sort of crescenteric appearance of the tendon that you can see on this image here, as opposed to the opposite side, which is asymptomatic, and the tendon has this more rounded appearance to it. So sometimes with the snapping hip, you'll see a difference in the morphology of the tendon. Other things that you can see sometimes are obviously fluid collections, and these, when there's fluid bubbling in and out along them, you can get a snapping sensation. So iliopsoas bursitis is something that's a common thing. Remember that the iliopsoas bursa can also communicate with the hip joint. So if there's a large hip joint effusion, you can see extension into the iliopsoas bursa. An intramuscular hematoma within the iliopsoas muscle can happen at times, and one should be aware of it. It's usually bright on T1 weighted images in the early sections, in the early stages. The rectus femoris, the proximal attachment of the rectus femoris is important. It has a straight or direct head that goes to the anterior inferior iliac spine, and an indirect head that goes and attaches along the superior lateral margin of the acetabulum. This is a common area for injury, and one should look at this area fairly carefully. Athletic pubalgia is a very important entity that one should be aware of. There's a great article in Radiographics that I would refer you to learn more about this condition. But essentially, the idea is that loads from the torso are carried to the lower extremity through something called the adductor aponeurosis, which is a fascial band that sits over the pubic symphysis. So you have the rectus abdominis above, the pubic symphysis below, and the adductor longus below, and the band of tissue that connects these two is the adductor aponeurosis. And you're basically concerned about overstraining or overstretching along this area. So what are the things that can happen? You can have a normal rectus abdominis. You can have a normal aponeurosis here and the adductor longus tendon. You can have, such as in this case, this fluid cleft that separates the aponeurosis from the underlying bone. So you have actually aponeurosis stripping. Or you can have what are commonly called, and here again you can see aponeurosis splitting, and sometimes you can see tears that happen along the undersurface of the adductor longus attachment upon the pubic symphysis. So these are the variety of findings that one would see with a potential adductor aponeurotic injury. As the disease progresses, you have aponeurosis stripping, you have tears. The tears can be seen on coronal images as these discrete splits or a cleft sign that we call. And along with this repeated stretch and repeated stress, what you can see is essentially bone marrow edema within the pubic symphysis, or even sometimes osteitis pubis. The hamstrings are another important portion which form the posterior tendinous attachment. There's the conjoint tendon, which consists of the biceps and the semitendinosus, and then there's the semimembranosus. The abnormalities are tendinosis, tears of varying grades, bony changes, bursitis, and calcification. So here is here is the proximal hamstring tendon. You can see the conjoint tendon here, and you can see the semimembranosus tendon here. Here you can see that there's a little bit of this fluid signal interposed between this, which is early stripping along that attachment on the ischial tuberosity. As this continues, you can see along with it there's the persistent stripping along with a little bit of bone marrow edema. In some cases you can see a fairly intense bone marrow edema along with this large fluid cleft, so it's just hanging on by a thread. You can see full thickness tears with large collections, and you can see sometimes a balled up tendon in the region. And you've got to be careful, because sometimes if you see just the balled up tendon and the tendon looks continuous, it may be an adjacent calcification. Posteriorly, the other thing we notice is the ischiofemoral impingement, and this is essentially the space between the lesser trochanter of the femur and the ischial tuberosity. When there's significant narrowing of this space, you can have impingement of the muscles running in this area, and you can start to see edema within these muscles, and you can see ischiofemoral impingement. Sometimes you can see an ischiofemoral bursa form, such as in this case, and this could be ischiofemoral bursitis, and that's another important entity to find. Sometimes you may even see the sciatic nerve subluxing into that space and getting intermittently impinged. This is probably more common in patients who are post-hip arthroplasty. So when we talk about the non-arthritic hip pathology, we've already gone through the intra-articular pathology on the previous talk. When we talk about the extra-articular pathology, we're thinking superiorly at the anterior superior iliac spine, where we're thinking about the sartorius attachment. Laterally, we're thinking of the greater tuberosity and the presence of the gluteus medius and minimus tears. The presence of a little bit of fluid, by the way, adjacent to the gluteal tendon does not always imply a trochanteric bursitis. That's more of a clinical entity than a imaging diagnosis, because we can often see a little bit of fluid and edema in people who are asymptomatic as well. Anteriorly, we focus our attention on the psoas muscle and the lesser trochanter, and then the rectus femoris at the anterior inferior iliac spine, as well as the superolateral margin of the acetabulum. Posteriorly, we focus our energies on the hamstring and the ischiofemoral space, which are common areas that could be affected. So with that, we'll end our second talk on MRI appearance of the non-arthritic hip pathology in the extra-articular locations. Thank you very much, everybody, and stay safe.